my screen and introduce our guest tonight. Welcome back, our guest tonight, Dr. Audrey Baker, a Manzanita mom and physician here in Tucson at Banner, is with us tonight. So without further ado, I'm going to let Audrey just take it over and go ahead and share her screen. And thank you all for joining us tonight.
Thank you so much for having me, Mrs. Bowling. I just want to thank you.
I can't hear you, Audrey.
Oh, okay. You can't hear me at all, huh? Can anyone else hear me?
Oh, there, we got it. Got it.
Okay, is it good? Okay. I just wanted to thank you. My sons are having a great time going to in-person learning, and I watch what's happening in the rest of the nation and really the rest of the world, and I'm so grateful that all of the mitigation strategies at Manzanita have remained rock solid and are really working. From the end of October when we first opened, the community transmission rates were very different than they are today. But the Manzanita transmission rates have been totally zero. So to me, what that means is Manzanita is a safe place to be right now. Just the other day, I was joking around with one of the anesthesiologists in the hospital. And we were talking about how some of our colleagues have contracted the coronavirus, but it hasn't been in the hospital. People are safe at work. People are not safe when they go home and they're either with their families or they're at a gathering with other families or they're going into in-person dining. That's where a lot of the transmission is happening. So we feel safe in the hospital and we feel safe at Manzanita too. So thank you to you and to the teachers and to your wonderful leadership for making that a possibility. That aside, I'd like to talk about the most exciting thing. I'm going to try to share my screen. This has really lifted everybody's spirits, both in the hospital and worldwide. And it's just a really fun thing to think about and to talk about is what's coming very close on the horizon, which is a mass vaccination for the coronavirus, which is really going to change everybody's lives. Not back to normal, but closer to normal than we have been in a long time. What I'd like to talk about today is really viruses and vaccines 101. So this is a very basic primer on what is a vaccine, what is a virus, why everybody in our community should be vaccinated if possible. What are the current different vaccines developed for COVID-19 and which ones will be available to us in our Tucson Manzanita community? And the most important thing is, when can I be vaccinated? So the first thing to understanding vaccines is we have to understand what we're fighting against. And what is a virus? And a virus is just a tiny little piece of genetic material, either DNA or RNA, that's in a little envelope. That's it. It's not alive. It's not dead. It's kind of in limbo. And the only point of a virus is really to make more viruses. They are obligate intracellular parasites, which means they can't replicate on their own. They need a living being, either a human or an animal or another bacteria or another virus. They need some help making more of themselves. And what they do is that they enter a cell and then they redirect the cell to make more virus particles. I had a really inspiring virology and immunology professor in medical school, and he would talk about, what is the meaning of life? More life. And what is the meaning of virus? More virus. That is the only thing the viruses care about. And what I'm showing here in this slide is actually how a virus will enter into a cell. They use a lock and key, and the lock are all of these various receptors on the cell surface membrane. They can be different viruses attached to different receptors, and we'll talk a little bit more about the coronavirus and its specific receptor a little bit later in the talk. But the virus gets in, It gets into the cell. As you can see here, it completely reworks the intracellular machinery so that the cell isn't doing what it's supposed to do. The heart cell isn't doing heart cell stuff. The lung cell isn't doing lung cell stuff. All it's doing is making more virus. So what is the meaning of virus? More virus. Interestingly, what is a vaccine? Well, the vaccine is just a product that is going to change the immune system and train it to fight off a particular disease. What we think about is train hard and fight easy. So we try to give the virus a lot of leeway here and let the immune system train itself on either viral particles or an inactivated virus or just the DNA or RNA of the virus it's trying to produce. And we'll talk a little bit about the differences in the various coronavirus vaccines. So interestingly, there are many paths to immunity. You can either get infected, you can have a big viral load or a small viral load, or you can get vaccinated. And the beauty of vaccination is that you don't get sick. You have a very low risk of adverse reaction, and it greatly outweighs the risk of complication that you would have by a natural virus. In any vaccine talk, you have to talk about Dr. Jenner. This guy was really amazing in his time. He was a surgical student, and surgery students at the time, I mean, they were into some weird stuff like bloodletting and amputating. I mean, it was really barbaric. But he lived in the fields, and he had a lot of interaction with different farming communities. And what he noticed is that farmers and milkmaids who contracted something called cowpox, which was a very mild disease that gave you these little warts on your fingers. In those patients, they did not get smallpox, which at the time was a very deadly disease. So what Dr. Jenner did is actually scraped some cowpox off of one of his patients and inoculated an 8-year-old little boy. It wasn't his boy, it was his gardener's son. I mean, this kind of research we could never do today, obviously. And he inoculated this 8-year-old boy with cowpox, followed by a few weeks later, exposed him to smallpox. And the 8-year-old did not get sick. And this is really the first vaccine program, if you could call it that, in history. Smallpox is the only eradicated infectious disease. It was, I think the last case was maybe in the late 70s, and there have been 0 cases since then. Unfortunately, that probably won't be the case with the coronavirus. The reason we were able to completely eradicate smallpox is because it does not have an animal host. So there isn't a whole bunch of animals around there with smallpox that can reinfect the human population. Vaccines are the safest path to herd immunity. So if there's one slide I want you to remember from this whole talk, this is the one. You know, there are a lot of different ways to become immune to a specific disease. And especially right now, there's a lot of chatter about natural infection. You might hear people talk about variolation. And what that is it's still natural infection, but a smaller amount of the virus as safer than a larger amount of the virus. While this is true, it is not 100% safe, and it is certainly not as safe as a vaccine. Remember that this virus, the coronavirus, is unbelievably successful. At some point, we're all going to either get it or get vaccinated, but it is an unbelievably contagious virus. When we talk about herd immunity, we're talking about the entire population or most of the population being exposed to either the vaccine or the virus itself, and what is the safest way to get there. So on the left of the screen, you can see this is a schematic of what it looks like when there's no herd immunity. So to orient you, the blue people here are susceptible, and the red people here are infected. And you can see when there's no herd immunity through a community, I went too far. it can really spread through the community very quickly and very dangerously. Going over to the right side of the screen, the blue people are still susceptible. The red people are still infected, but these green guys in here, these people are immune, either through a vaccine program or through natural immunity. And what you can see is that these susceptible individuals are protected by all of the green individuals between the red and the blue. When we talk about getting an individual vaccine, that protects you, the vaccinee, the person who is getting vaccinated. The current vaccines we have now are up to 95% effective, which is absolutely wonderful, meaning out of 100 people who get vaccinated, 5 of them may catch the virus, the other 95 will not. But when we talk about our community at large, there are some people who will not be able to be vaccinated, either because they are immune compromised and they won't mount an appropriate antibody response against a vaccine, or they're the very young or the very old, or some people will choose not to get a vaccine. And they will remain, as this picture, as the blue individuals. They will be susceptible. As long as there are enough vaccinated people in the community, they too will be safe. So speaking about herd immunity, we are talking about vaccinating or having antibodies with a large proportion of the population to keep those who can't get a vaccine for whatever reason, to keep those patients safe. The target of all of the current vaccines is the spike protein. I know most of you are probably familiar with the schematic of the coronavirus, and hopefully you can see my pointer here. The coronavirus is a ball, and it has all of these sticky spikes all over it. The sticky spikes are what enters the cell. We call this the spike protein. It's big and it's clunky. And when your immune system sees the spike protein, it's actually creating many, many different antibodies to lots of different parts of the spike protein. And that'll be important when we talk about the variants that are coming up. Here you can see the coronavirus is entering the cell via something called the ACE receptor. Now, the ACE receptor is on lots of different types of cells in the human body, the heart, the lungs, the GI tract. Some of you might be familiar with a drug class called ACE inhibitors. They're blood pressure agents. And the ACE receptor is really important in regulating big overall hemostatic functions like blood pressure, like intracellular volume, inflammation, wound healing. So it's a very ubiquitous receptor that the coronavirus can attack. The theory is that if your body can make antibodies to the spike protein, once the virus comes into the body, the antibodies will completely neutralize the target before it's able to enter the cells. There are 3 main types of coronavirus vaccines that are currently in development. The first is protein-based, where either you take the entire virus and inactivate it and inject it, or you just take the spike proteins, and they are already inactivated because they don't have any virus attached, and you inject that into the muscle. The body then sees the protein and produces antibodies. The second class of vaccines that we'll talk about have a vector, meaning it's not the actual virus, but scientists have placed the RNA, remember the genetic material of the coronavirus spike protein, into a separate virus that is not virulent, that doesn't make you sick. These are usually adenoviruses that have been genetically modified to produce the spike protein rather than copies of itself. And then finally, what we'll talk about is just the mRNA vaccines, which is just a tiny little piece of genetic information covered in a waxy bubble. And then the body itself will produce the spike proteins to which we can produce antibodies. This last class I want to talk about first, and that's because this is what is currently being used in our community to immunize the population. Both the Moderna and the Pfizer vaccines are RNA vaccines. And up here you can see these are little vaccine particles. It's just a tiny little piece of RNA, and it's in a waxy bubble. It's interesting because this waxy bubble is proprietary. So Pfizer has their own waxy bubble and Moderna has their own waxy bubble, and nobody talks about what's in their waxy bubbles because that's what they take to the bank, I guess. The interesting thing is because RNA is quite fragile, the waxy bubble makes all the difference, which is why the Pfizer vaccine needs to be in a very, very cold freezer, -80. The Moderna vaccine also has to be in a cold freezer, not as cold as the Pfizer vaccine. And that has to do with what types of molecules they've created their waxy bubble. I wish I could talk more about it, but they wouldn't give me that information when I called earlier. So what happens with these waxy bubbles is that they actually bump into the waxy bubble around each of our own cells. So in this slide, you see this big blue cell. This is our cells. This is the vaccine particle bumping into one of our cells. And what it does is injects this tiny little piece of RNA. RNA is kind of a quick and dirty copy of the blueprint of the protein. Our own cells produce the protein and then produce it as a spike protein on our own cells. This is not infectious, but it does allow our own immune system to recognize the spikes on the edge of the cell. This is the B cell. The B cell is what produces the antibodies. So your own cells will be producing the spike protein of the coronavirus. The B cells recognize this as foreign and make a ton of antibodies against it. When your own cells express a foreign protein, it is highly immunogenic. It sets off all of the alarms in the human body: the T cells, the B cells, the antigen presenting cells, the macrophages, the whole gamut of immune system is looking at these foreign proteins on the surface of your own cells. This is in contrast to if we just were to inject you with the protein. It still elicits an immune response, but it is not as robust. That is why the RNA vaccines have been so helpful in the fast generation of an immune response. The other neat thing about the RNA vaccines is that they're very quickly modified. So, over time, the coronavirus is going to be subject to different environmental pressures, and it will undergo genetic shift, meaning there will be mutations in the spike, and there might come a time where our current mRNA vaccines are not similar enough to the spike protein to where your antibodies are going to recognize the spike. The neat thing is that the RNA vaccine is very easily changed. So if we see a change in the type of spike in the community, we can change the RNA vaccine on a dime. And what the companies are saying currently, it would only be a 2-month lag period to create a new vaccine. I know many of you are familiar with getting a new flu vaccine every year. The nice part about the coronavirus, if there is a nice part, is that it seems to be changing very slowly. It changes more slowly than influenza. However, our vaccine can change more quickly. So there's a lot of talk about the current coronavirus variants, both in England and South Africa. However, it's not worrying scientists yet because the current vaccines are working against the variant, and then they know with the current RNA technology that they'll be able to chase whatever variant comes their way. The antibodies, once circulating in your body, can then attack any virus. So these Ys are antibodies here. And remember, even though this schematic is just showing one type of antibody hooking on to that spike protein, every spike that's generated is generating multiple antibodies to recognize it and destroy it the next time your body comes in contact with it. The AstraZeneca, Johnson & Johnson, and actually the Sputnik vaccine, which made the news a few months ago when Russia started vaccinating their population at large without the benefit of clinical trials. It's actually a very similar vaccine to the AstraZeneca and the Johnson & Johnson, which are undergoing very rigorous testing here in the United States and over in Europe. This isn't just a waxy buggable with a piece of RNA. This is actually a virus with a piece of DNA. Now, the DNA is encoding the spike protein. So after the cell receives the adenovirus, the normal machinery takes place. It will then create a copy of the DNA to RNA. It will then transcribe the RNA into a protein and display the spike protein on the edge of the cell. The only difference is that instead of directly infecting a cell with RNA, you're using a vector virus. Now, this adenovirus, there's lots of adenoviruses. Many of the common colds that we catch every year are adenoviruses. But this adenovirus has been genetically modified not to replicate itself. So the adenovirus itself is not transmissible. But what is transmissible is this little piece of DNA, which will encode the spike protein. And then finally, there are the protein vaccines, Sinovac, Sinopharm, Covaxin. These are not being widely tested right now for use in the United States, although they may in the future. These are based on proteins, either taking the spike itself and distilling it and injecting the spike itself, or injecting the entire coronavirus. What you do is you first grow the coronavirus in cells, and then you treat it with chemicals to completely inactivate it. So it's really just viral proteins that are getting injected, to which your immune system can then respond. Now, as you can see, this is a different cell. This is something called an antigen-presenting cell. And what these are is this is the interface between your immune system and the virus. And these are cells within the immune system that will eat a foreign object and then present the foreign object, these are the little proteins in here, on their surface to show the helper cell and then to make antibodies through a B cell. This is not usually as immunogenic as if the proteins were on your own cells. So sometimes inactivated vaccines do not create the antibody spike that you want to see as do the adenovirus or the RNA vaccines. And then finally, I wanted to talk a little bit about the COVID variant. I get asked a lot of questions about this when we talk about this in the hospital. And, we've been talking about this red protein, which is the spike protein, and this is susceptible to genetic pressure. The current B117 variant that is circulating in London and the rest of Europe right now, it actually has, I think it's 23 mutations that have that they are all located within the spike protein. But interestingly, the current vaccines and the current antibodies people are producing to that vaccine are still reacting with even the variant protein. They think that it's a little bit more contagious because what the mutations have done is creating a stickier spike virus. So it sticks to those ACE receptors with more affinity. Once it's in the cell, it's thought to create more virus particles than the original coronavirus that we had been dealing with last year. That being said, it is not a thought at this point to be any more virulent, meaning it does not produce any worse symptoms. It is not more dangerous in that it is, each infection has the same likelihood of landing you in the ICU or recovering completely. On a whole, if you have a more infectious virus, on the whole, it will affect your population in a very different way because more patients are going to get infected. However, we're in a little bit of a race between vaccinating a population and achieving herd immunity and these various variants that will become more prevalent. I want to go on to the Arizona COVID-19 vaccine prioritization. Now, I pulled this for the Arizona Department of Health Services. Right now, we are in phase 1A. Okay, whoops. Let me go back. Phase 1A, including healthcare workers, emergency service workers, and long-term care facility and staff and residents. It's interesting because how the state has decided to move from 1A to 1B to 1C really depends on how many healthcare workers, how many vaccines are available within each county. So it's not actually by a state that we're going to move from one phase to another. It's actually county by county. And just today, on calls with the Pima Health Department and the hospital, this has also been in the news today that the Pima Health Department is hopeful that they will start vaccinating patients in 1B as soon as next week. So 1B is including a lot of essential workers and education and childcare workers. So that's going to be really, really key to keeping our Manzanita community safe. We don't know how long phase 1B will last. That really depends on how much vaccine we are able to get from the federal government, and also what the rollout procedures are. I know it's been in the news that the rollout of the vaccine has been very slow. It has been, but it's quickly ramping up. And as soon as next week, there are going to be multiple sites available for drive-through for phase 1A and 1B patients. So we're pretty excited about that. This was pulled off the Pima County website, and you can see Pima County is in phase 1A. There are a few counties in Arizona that are now in phase 1B, but Pima County actually has the highest vaccination rate in all of Arizona, which is really wonderful. If you look at vaccination rates, 14%, 20% in other countries, it can be a little bit demoralizing. We have gotten a little bit of a slow start here in the United States, but I'm hopeful that will quickly ramp up as we have more centers open. So I'll leave you with my own vaccine story. I actually participated in the Moderna trial in August. I was very excited to be a part of the phase 3 trial. I did receive the vaccine. It was unblinded last week. So I will tell you, the second shot, I got a few symptoms. I was a little tired, but I would take a little bit of fatigue over COVID-19 any day. So with that, I'll open up to questions, and thank you so much.
Thank you, Dr. Baker. If anybody wants to type a question in the chat box, they can, or go ahead and unmute. We could do that as well. We're a pretty small group. Thank you for your time and an incredible presentation. You've got a very effective delivery style. We make it very understandable. So thank you, Audrey.
It's my pleasure.
What questions are out there? You were so thorough. Maybe we don't have any.
It looks like if one tests positive for the virus, should they get the vaccine? I think the answer is yes. The only current contraindications to the mRNA vaccines that are currently available are, one, if you've had any other vaccines in the last 2 weeks, or so don't get your flu vaccine right before you're going to get the coronavirus vaccine. You got to wait 14 days. Or two, if you've ever had an anaphylactic reaction to the coronavirus, not to any vaccine. The anaphylactic reactions are making the news, and they're really scary, but they are exceedingly rare. You are more likely to die from an anvil dropping out of the sky than you are from an anaphylactic reaction. That being said, every vaccine station has a waiting period, so you got to wait for 15 minutes. The only anaphylactic reactions we've seen has been in patients within 15 minutes. So you got to wait 15 minutes after you've been vaccinated to make sure everything's okay. There's a doctor there on premise. I might be there on premise. I've been volunteering at the vaccine clinic myself, and we haven't had any problems here in Tucson. There was a couple cases in Alaska, which was strange. It was all in the same hospital, so I'm not sure what was going on there. The other piece I want to say while I'm talking about reactions to the vaccine is that there have been some reactions in patients who've had cosmetic filler. So there have been a few reactions, both with the Pfizer and the Moderna vaccine, in patients who've had lip filler or filler in the brow, and they'll have all this lip swelling or this brow swelling. It will go away, but it's thought to be an immune response to another foreign body in the body. So if you have lip filler, awesome. It's okay. You should still get your vaccine. You might really blow up a little, but you might like that. I don't know. Okay, let's go on to the next question. Could you say a little bit about what makes mRNA vaccines safe? I'm not sure how to answer that question. This is, maybe it's speaking to the fact that this is the first mRNA vaccine that has seen the broad public. It has undergone extensive testing in animal models, in rats, in mice, and in non-human primates, aka monkeys. It has an exquisite safety profile in phase 1, phase 2, and phase 3 studies. Now, only the phase 1 studies are available for public consumption right now. So the phase 2 data and the phase 3 data have only been reviewed by the FDA. So we can't see those publications. But there was a publication in the New England Journal of Medicine over the summer showing the safety and the efficacy in the phase 1 trial. At this point, the Moderna vaccine has gone out to 15,000 people. There were also 15,000 controls. And the Pfizer vaccine, I think, has gone out to 20,000 people in clinical trials. Now, in the population at large, there's been millions of vaccines administered by now. So what makes an mRNA vaccine safe? I don't know if you can say 100% with certainty that in 10 years we won't know something new, but with the information we know now, it's very safe, and it is certainly safer than rolling the dice and catching COVID-19. Are we going to have a yearly vaccine for COVID like the flu? Probably. Or is it a one-time thing? Probably not. I think the coronavirus is here to stay. It has animal reservoirs. So even if it's completely eradicated in humans, which it won't be, but even if it is, it still exists in mink and pangolin and bats, so it's going to come back. So people think that once a year we're going to have to get our flu vaccine and our COVID vaccine, and they might be combined, which would be nice. It would just be one shot. But I don't think we're going to live without COVID anymore. I think it's going to be the next influenza. How will we know where and when to get our vaccines? Please visit the Pima Health Department website. There is a form you can fill out. Now, employers can fill out if they're eligible for 1B, and I'm not sure if the Catalina Foothills District is doing this for you. But honestly, if it was my vaccine, I would just do it myself. And if Catalina Foothills does it for you, wonderful, we'll do it twice. The Banner Health website also has a portal that I think will be opening next week for Category 1B. I've never been so excited to get a shot. I know, me neither. I have to say, I have been volunteering at the vaccine line to make sure, nobody has an anaphylactic reaction. I stand there with my EpiPen. Not really. I pass out candy canes. But my favorite part about being in the vaccine line is talking to people after they get vaccinated. I'm going to tear up just thinking about it. I mean, it's really a relief for so many people. And it's just a wonderful time to be part of the scientific community and to be part of the Tucson community and to be there when, all of people's anxieties are kind of coming out after their shot. And, I tease them and I say, we're all just teary because it hurt. We'll just blame it that it hurt. But, it's a relief on the biggest scale. And it's really wonderful to be part of these clinics.
Well, Dr. Baker, we thank you for being part of our community and being willing to just spend a little time with us from time to time. So I will thank you. And we wanted to kind of keep this at about 30 minutes, and we're just a little over that. So it doesn't look like there's more questions in the box. We will sign off and maybe visit again in another month or so. We'll see what other topics we might have of interest. If anybody has feedback, we aren't going to send out anything formal, but feel free to send me your thoughts on email or Blooms. I'm happy to pass that along, and any other topics that you'd like to hear us talk about. Have a good evening, everybody. We'll see you.
Thank you for having me. Thank you so much.
Thank you. Good night, everyone.